Hi, Dr.
Can you
Suresh.
hear me?
Yeah, very well, very well. It would have been a very
Hello to the lab.
tiring day for you. Now it is, what time is it? 4 o'clock in the evening, right?
I can imagine what would be your feeling.
Here,
Your morning cases were excellent.
here,
So what is it that you have come up with now?
we have two patients. One is having a combination of pulmonary artery stenosis with a large residual VSD, and on the other side we have a complex tricuspid atresia post Fontan surgery with persistent antegrade flows and fenestration flowing right to left, combination of left to right and right to left, all causing harm to the Fontan circulation. So whenever you feel that we are ready to go live, we can start with our PowerPoint presentation. We can discuss the cases. Is things ready there?
I think you can start with your PowerPoint presentation.
Yeah, thanks, Dr. Bharat. One of my
ready, Shiva?
Yeah, okay. One of our colleague will start.
We have 6 years female child whose primary case of tetralogy underwent intracardiac
Are you hearing,
repair.
Dr. Bharat, the audio?
Yeah, very well.
Okay.
Yes, loud and clear.
Underwent intracardiac repair with transannular patch in 2016. Post-op period was complicated by bilateral diaphragmatic palsy needing diaphragm plication. Complete heart block, so underwent epicardial dual chamber pacemaker and prolonged ventilator dependency. Currently child is having breathlessness on exertion, NYHA class 2 and history of slow weight gain. On examination, she weighs 15.5 kg with 96% of saturation, pulse rate is 90 per minute regular. S1 is normal, S2 is split. There is grade 2/6 ejection systolic murmur in the pulmonary area and grade 2/4 early diastolic murmur in the pulmonary area. X-ray shows cardiomegaly with cardiothoracic ratio of 70%, right atrial enlargement. Pacing wires are in position, sternum wires seen, thoracic and lumbar kyphoscoliosis. ECG shows A-sensed V-paced rhythm. QRS axis is negative 75. QRS vector is negative in inferior lead, suggestive of RV apical pacing. Subcostal view showing good biventricular function. Parasternal short axis view showing large perimembranous VSD shunting predominantly left to right. VSD measured 12 mm on the echo. There was also LP origin stenosis. LP origin measured 5 mm and distal LP was 10 mm. We did a cath. So in cath, from mixed venous saturation of 60%, there was a step up to 78% in the PAs, and on oxygen the step up increased further. PA pressures were 76/18 with mean of 42, and there was a gradient of around 30 across the LPA. On So basal PVRI was 2.77, which decreased to 0.77 on oxygen. This is LV angiogram done in LAO view showing large residual VSD. LP angiogram showing LP origin stenosis and RPA angiogram showing good sized RPA. So final diagnosis, status post ICR plus transannular patch plus permanent pacemaker implantation plus left diaphragm plication, 12 mm residual VSD which is shunting predominantly left to right, no RVT gradient, free PR with LP origin stenosis, PFO which is shunting bidirectional, mild biventricular systolic dysfunction and mild IVC congestion. And plan is residual VSD device closure and LPS stenting.
What is the clinical status of this patient? Is that baby on ventilator or something?
Yeah, currently on ventilator right now. Dr. Suresh, you are able to hear us?
So that's for the procedure. Yeah. My question was he an ambulant child with controlled heart failure or in terrible heart failure so that you had to intubate and do something as an emergency?
No. Actually, the problem was this child had bilateral diaphragmatic palsy from which the child has not fully recovered yet. So now when we are doing the procedure on sedation, we were not very confident about how well the child will ventilate. You would have seen from the PowerPoint presentation, the aortic saturation was 89% in room air. The reason for that was there was a large residual VSD which was shunting left-right in systole. However, because of the free pulmonary regurgitation, there was a right to left shunt in diastole. The child was continuously saturating only in the 85 to 86% in room air, and right now let me tell you, on 70% FiO2 we are having a saturation of only 84%. She has got lot of blood that goes across the VSD right to left in diastole whenever there is a significant pulmonary regurgitation, which is always the case. So in view of that resting hypoxia,
there would be a ventilatory component, Shiva?
Possible. Because of the bilateral diaphragmatic palsy,
Shiva?
there is possible.
There is a bilateral diaphragm paralysis. No?
Correct. Ventilatory problem is also there.
Okay.
There is also the contribution because of the left pulmonary artery stenosis. The PR is quite a lot, and that PR is causing the pulmonary regurgitation is causing a right to left shunt in diastole. And that is also causing a problem. The child is even now saturating only around 83%.
Do we have the pulmonary venous saturation, Shiva, since there is a PFO?
Last time in the cardiac catheterization, can you just look at it was normal, Dr. Bharat, it was, just look at there was a step down.
Okay. So what is your plan?
The plan is, see, there was 98, okay, the pulmonary venous saturation was 95.2 with an aortic saturation of 84.7. During the previous cardiac catheterization, there was some degree of pulmonary venous, 95 is also not very high. It's possibly due to the mild ventilatory disturbance caused by this diaphragm immobility, but there is also a contribution of lot of right to left shunt across the VSD in diastole. The net QP by QS was
absolutely, and
show that previous PowerPoint, previous picture. Yeah, you can see the left pulmonary vein saturation was 95.2 and the right pulmonary vein was 90.7. And the second one was on oxygen, it went up to 98.6. And of course, on that day it was on oxygen the saturation was going up, but today on a fully controlled ventilation, still the saturations are a little low. The problem that today's hemodynamics are,
Shiva,
yep. Yeah, Zahid.
Shiva, Dr. Zahid has joined us.
I was going to ask you, did you do the saturation on room air or 100% oxygen?
During the diagnostic cath on room air. During the diagnostic cath.
Okay, so the pulmonary venous sats of 90, what was the PO2? What was the PO2?
Just 1 second. Open the cath. It was for the 90.7, the PO2 was 62.2, and the left pulmonary vein was 95.2 and the PO2 was 84.5. The PCO2 was
so
35.
Do you want to rule out lung disease and
Zahid, I was telling there is a bilateral diaphragm palsy.
You want to rule out lung disease by giving him 100% oxygen?
Zahid, bilateral diaphragm paralysis.
And today, even on controlled ventilation, the saturation is only 84% now. There may be a lung disease possible.
Okay.
Go ahead. So what is your plan?
So the plan was, since the VSD was resulting in keeping the right ventricular pressure and pulmonary artery pressure at systemic levels, we were thinking about closing the VSD. And since the left pulmonary artery which was repaired is having a significant narrowing with a gradient of around 40 or so, to stent the left pulmonary artery. You also would have heard that there was one MAPCA that was unifocalized. There was an aortopulmonary collateral that was exclusively supplying the right medial basal and posterior basal segment, which was directly anastomosed to the undersurface of RPA, and that PA also was narrowed. Can you show in that PowerPoint RPA angiogram? Is it there? Just go to the PowerPoint. Yeah, show the RPA
Shiva.
angiogram, the right side.
Shiva,
Yeah.
I like your cap very much. I like the cap you are wearing.
Okay, that's a lead cap, Zahid. Okay, you can see that the unifocalized vessel. Freeze it. Somebody freeze that right pulmonary artery angiogram. So freeze it and just move the picture till the that unifocalized vessel comes. Yeah. Okay. Sorry.
I think Shiva, first you must close the VSD,
Yeah.
maybe restudy the hemodynamics, and then take a call regarding, addressing the pulmonary artery narrowing.
Anyhow, pulmonary artery narrowing with gradient
I
of...
think Shiva, I agree with you. I think you should address.
Yeah, both we will address. Okay, so now, right now our plan will be, since we are going live with you, we thought we will have both ready. So I'll tell you what we have done. So go to the first picture. Go to the first picture. Okay, run it. So this is this is that unifocalized vessel that we entered. You can see that that unifocalized vessel is having an ostial narrowing. Just freeze it. While the right pulmonary artery was having a pressure of 70, this vessel distally was having 25. Next picture. So then we did a lateral on this, and it was supplying only the medial basal and posterior basal segments. Next picture. So what we did was we then made a pictile angiogram, freeze it. Yeah, okay, just go back. You can appreciate the anastomotic narrowing of that vessel, and there was, as I mentioned to you, it was 25 millimeters distally. So what we decided was we will go and balloon dilate that area. Next picture. So we put a 9 millimeter Mustang balloon. You see the way it is dilating. So this is proximal. Next. You see there is a waist, and the balloon is getting milked. Next. So here when we are inflating, suddenly the proximal area was going bigger. So immediately we stopped the inflation. Then we entered with a right coronary guide catheter. Next picture. And we made an injection. We found that there was a hyperperfusion lung injury. It was not actually a bleed. It was an intense hyperperfusion lung injury. With that particular segment was having 70 pressures. This place, the place where my catheter was there, it was having 70 pressures, and there was a hyperperfusion injury. There is no bleeding, there is no endotracheal bleed and all. Next picture. So then I withdrew a little bit. You can see
that flow on medial side.
What?
Shiva.
Where is that?
Shiva.
Yeah.
Sorry to interrupt you, but what's that flow on the medial aspect? What is that on the medial aspect going towards the spine?
It is all the hyperperfusion lung injury of that small
Shiva?
segment.
Okay.
Shiva?
Yeah.
Yes.
Yeah.
This is Henry. This looks like a pseudoaneurysm. The vessel has disrupted. It's much larger than the rest of than the way the vessel looked before.
Okay.
And that's consistent with the way that waist suddenly opened up.
Okay.
I think it will heal. It's not. There's some localized extravasation, but I think it's probably stable.
I will do an angiogram after we complete the other steps.
Was,
yeah.
The second issue, Shiva, was that the stenotic segment has not given up all that much to really cause the hyperperfusion injury.
No, sir, Bharat, actually the distal pressure, which was 25, went up to 65 to 70 after the dilatation. You can see some tear in that proximal ostial area. Can you see that? Some torn segment with some
We do see it.
Yeah. Okay, anyhow, since the hemodynamics were stable, there was no endotracheal bleed, we left it there. Next picture. And then we entered into the lift. So freeze it now. Freeze. Just go back. Go back. Yeah, this was the left pulmonary artery ostial narrowing. So show the measurements now. Go to that photo and click the photo. The measurements were about 14 millimeters to 15 millimeters in the hilum. That is, it's around 4 to 5. This is around 14. And we were just making some assessment about what sort of length of the stent may be there. But these are the two numbers. Like it's around 14 to 15 on the hilum. And in fact, you can see that the ostium of the LPA is even smaller than the measurement that has been made. The measurement is little bigger. To the right of that measurement, it's even smaller. So somewhere around 4.5 may be the ostium of the LPA. Next picture. Next picture. Next. Yeah. So then we made the LV angiogram. The LV angiogram shows that there is a pretty large defect.
So Shiva, before you move away from the pulmonary arteries, let me ask you a question.
Yeah.
Can you hear me?
Yeah, yeah.
Shiva?
I'm hearing you, Dr. Suresh.
Yeah, Madi, before you move away from the pulmonary arteries, that pulmonary artery balloon dilatation in this complex combination of problems is the best thing that you could do. But supposing you were dealing with it as an isolated problem post-TET repair, would you be happy with what has happened, or would you go ahead and stent those pulmonary arteries?
You are talking about
if
that...
you did not have any other problem to deal with.
You are talking about that unifocalized small vessel or the big LP artery?
Unifocalized MAPCA.
Yeah.
I'm referring to both in the sense that, say, your patient has severe pulmonary regurgitation.
Yeah.
Supposing he did not have any other problem,
yeah,
would you try to normalize those pulmonary arteries to the extent that it is possible? Child is 15 kg, no? Not very small.
Yeah, that unifocalized pulmonary artery, which was hardly about supplying only the medial lobe.
Shiva,
yeah. Yes.
Shiva, we have 2 cases to go.
Yeah.
So I think you start.
So what I will tell you where we are.
If I could.
So I will go for stenting of the left pulmonary artery, but I will go for a balloon dilatation of that unifocalized small
Shiva,
branch.
1 second, Henry.
No, there was a question, no? He's answering that question.
Shiva, hang on. There is a question from the audience.
Shiva,
yes,
since you have a large VSD,
yeah,
right now the pulmonary artery stenosis is acting like a band.
Yeah.
It's protecting the child from over-circulation.
Yeah.
The child will become very unstable and then could have very serious bleeding from the right lung,
yeah,
at the site of the pseudoaneurysm and the disruption if you have uncontrolled increased flow in the lungs, or pulmonary hemorrhage in the left just from increased flow.
Yeah.
I think right now I would close the VSD.
We are doing that.
And then deal with the pulmonary stenosis later rather than make the child hemodynamically unstable.
No, we are going to do that VSD now.
I agree with Henry. So if you can get the VSD, then you can work on the others.
Is that Allison?
I know. I'm sorry, but I think he should address the left PA.
No.
But before or after VSD closure?
No.
Okay, so right now my plan was to close the VSD first.
To address LPA stenosis, I think it needs to be addressed.
No, I'm going to close the VSD first, because if I
close the VSD first.
Yeah, because if I open the left pulmonary artery, there is going to be hyperperfusion of the left lung also. So I'm going to close the VSD first, and after closing the VSD, then I'm going for the left pulmonary artery. So I'm going to close the VSD retrograde. So I have put in a 7 French LifeTech VSD delivery system across the VSD. And
what is the size of that VSD, Shiva?
12 millimeter on 12
what
millimeter.
What is the size of the VSD?
12 millimeter on echocardiography.
Oh.
So I'm taking out the wire now.
And this patient had surgery.
Yeah, surgery was the one that was very complicated with bilateral diaphragm palsy, tracheostomy, complete heart block, pacemaker, everything. This child stayed with us for 2 months, 2.5 months. So right now we are going to address this residual VSD. Since it is a 12 millimeter residual VSD, ideally we should be taking something like a 14 millimeter muscular VSD device. However, a 14 millimeter Amplatzer muscular VSD device will need an 8 French sheath, whereas a 12 millimeter muscular VSD device will need a 7 French sheath. So I thought of giving a try with a 12 millimeter first and see whether I can get out with femoral artery sheath of only 7 French. So right now I have a 7 French LifeTech VSD delivery system, which sometimes may look
Shiva,
undersized.
Can you explain why you want to go from the left side?
Because
I know the reason, but can you explain for the audience why you want to go from the left side?
See, this was a double outlet right ventricle with an aorta that was anteriorly placed, and the VSD is located bang right underneath the aorta, and it was more anterior. If I have to take a arteriovenous circuit, the circuit will go all towards the left side of the patch and then enter into the aorta, and I may find it difficult to turn it into the left ventricle, the sheath into the left ventricle. So finally I might end up in deploying the device from the aorta down. I thought going retrograde is an acceptable strategy.
Okay.
Shiva, is this an additional VSD or is this a dehiscence of the patch or something?
It is a dehiscence. It's an anterior dehiscence of the patch.
Shiva?
Yeah, it's an anterior dehiscence of the patch.
Ah, okay.
I think there is a phase delay between the time that I am talking and the time that you are. So
we can hear you well though.
Yes.
My 12 millimeter Amplatzer muscular VSD is struggling through the 7 French LifeTech sheet. However, it's moving. Ramya, I need your help. So Ramya is going to show the VSD part. Can you get into apical 4 chamber? Apical 4 chamber, so that I start coming towards the VSD. Can you give a little bit of sedation?
You're doing a transthoracic.
Yeah. This is the last but one patient of the day, and so we did not want to get that pediatric transesophageal echo probe. Okay, so is that the best possible image? Apical 4 chamber if possible, correct. That's better. Little bit more apical so that you really see 4 chambers. Yeah, the device. I'm coming closer. Okay, can you put the color now? Okay, I'm not seeing much. Okay, now go to parasternal short axis and get the same picture. So you have to see the device in the right ventricle. Show more of the right ventricle. Color now. Color now. I'm not seeing much. Okay. So that is the VSD.
Can you see the tricuspid valve in relation to the VSD device?
It is it's anterior. You see that? It's very anterior. Okay. Now Ramya, your hands off.
Shiva, we have another 3 to 4 minutes before we switch to China.
Yeah,
so
I understand. I understand. Now come again on the VSD. Quick. You have to keep on doing quickly.
Take your own time, but I just want to give you the time frame.
Yeah. Okay.
Do you have another arterial line where you can do an LV angio and get some idea?
I don't have, Dr. Zahid. The problem is there is a right femoral venous occlusion in this child already. I have gone through the left femoral artery and left femoral vein.
Okay.
I don't want to lose more and more vessels in this child.
Agree.
Okay, color. I'm coming closer and closer. Okay, color off. Make the picture very large. No, not that way. Depth down. In between I heard a voice. Is it Alison Kabalka?
Yep, Alison is there.
Hello.
Hi.
How are you?
Hi, fine. Doing
Having a good time. I'm wondering, just one question about the VSD. Is it possible there is more than one exit into the RV side? Because we did not see you cross it.
Okay. No, it was a big patch dehiscence, Dr. Allison. It was a very big patch dehiscence. It was just one large simple VSD. Okay, I am not able to get any sort of angiography. Now I have to go by echo only. I am not able to get a side arm angio. We have come into the LVOT. Is that right? Sure? Or am I still across? Show the color.
Shiva, the thing is, since you did not have another arterial access,
it becomes very difficult.
It would have been good to have at least a transesophageal.
Yeah.
So that,
okay.
You could have some good consistent imaging.
I understand.
To decide the positioning, because the VSD is pretty large.
Yeah.
If it's a 12 millimeter, it's going to hang a lot in the aorta. So you have to make sure you don't trap the aortic valve.
Okay. Now I have positioned it. Now let me go and try to do some angiography. Wait, let it dear. The sheath has to dear. Yeah, can it hold it tighter?
Do you think it's all on the left side?
You see now my angiography, can you see the faint puffing there, Alison?
We saw it.
Yeah,
we saw it.
The problem is I have chosen
Explain it to us and answer Alison's question about
what
the
was
discs.
The disc is, now go back to echo.
She asked you if the both discs are on the same side.
No, Alison.
No, right
Alison.
side.
Can you see that now?
You think,
echo.
can
you see that? It looks okay.
Echo looks.
Yeah, I can see that now.
It looks nicely placed.
We see the four-chamber long-axis view. There's just a lot of color interference also.
Yeah. One of the problem is the echo pictures are also bad in this child due to the crowded chest, and yeah. Okay. I'm going to make another trial of an angiography. Let me see. I'm not getting good quality images.
You want to do an RV angiogram, maybe?
but I don't have a venous.
Do an RV angiogram?
I have already crossed the sheath with Okay. Now I think I have to go only by echocardiography. So show me the echo. Okay. So now this is the
go slow, take your time. Even
Yeah.
if you have to go back to China, we'll come back to you
Yeah.
when you are ready to when you are ready to deploy.
Yeah.
So you can take your time.
Bharat, I think it is fine, Bharat. I am able to see the patch on that side. Can you see here? See, this is the short axis view, the central aorta.
Yeah, to the extent that we see it, it looks quite good, Shiva.
Yeah. See now
I can see
you
it
see
across the VSD.
Yeah, this is the VSD patch, and it is on that side. Show the aortic valve now. Aortic valve color. But there is some residual flow there. If I release it, then I might know, because the cable may be tilting it.
Have you convincingly seen the aortic valve in relation to the VSD, the device?
The VSD was, the aortic valve was quite away from the VSD originally. There was a distance of some 7-8 millimeter. But now I have a rigid cable that is going across the aortic valve. Color it now.
Okay.
There is a lot of color flows everywhere that I am seeing. However, I have a gut feel that if I release it,
especially from the under surface of that device.
Leave it, the color out.
Shiva, I feel there is a lot of residue on the under surface of the device.
Yeah, one of the issue about this patch is color it. See, the patch is the rightward end of the VSD is formed by the patch, and leftward end is formed by the conal septum. So there is some. Yeah, now I am. See, that is the two discs on either side of the patch. Air is not there. If the moment I release the device, then I will have good angiography. I am reasonably confident that the device is in a good position, and so I am going to release the device. Can you show that LV angiogram once again, and now show me the fluoroscopic position of the device once again? See, that is the plane of the VSD. It's across that buttoned lead. And now show that last LV angiogram, last device position. Last device position. Yeah, this is the device. The device is across the buttoned lead.
I think, Shiva, I agree with you. I think it looks okay.
Yeah.
It's tough, very tough to tell, but I completely agree with you. I think looking at the previous LV angio and now looking at the device position, I think it looks okay, and there's a lot of
nicely.
Yeah, and it's orientated very well.
Now I have to make an angiogram and see how things are.
Yeah.
Can you hold it? But now my catheter is actually on the aorta. So what I will do is I will just do one aortic root angiogram in order to find out whether I have any AR. AR is not there. Now I have to carefully enter across the VSD, across the left ventricle, and then maybe I think it is fine there. I will do it later. First I will finish off because I have another sheath that is across the left pulmonary artery. Do you think it is stable? Come to AP view and show me once. AP now. Try another echo.
The way the device orientated and stayed there, it looks very stable.
Yeah,
right.
but
it remains how much residual shunt she has. But.
Yeah, residual shunt also. Yeah. See, the whole echo window is poor. Is it possible to?
I would do an LV angio
I will.
If you could.
I have to cross.
If you could do it an LV angio, that will be very helpful.
Yeah, I'll try to do that. Get me a 5 French pigtail. 5 French pigtail. Yeah. Come, quick.
Shiva, we have 1 minute to go.
Yeah. I'll try to
Show
see
us an LV angiogram before we move on to China and then come back to you.
Yeah. I'll try to get it within 1 minute. Yeah. Yeah. Go slowly. Okay. Come to the LAO. Come to the same LAO view. Is this the view? Zahid, I am really scared, Zahid. However, I know that
it's okay. I think if you're scared, if you're not comfortable, don't do it.
Then don't do it.
No.
Please don't do it. You can look by echo, and that will give you. Your wire is in good position. So.
The problem is it's late in the evening, and I have to fly to Frankfurt tonight. Okay, come. Angio.
I think.
Don't embolize anything, though.
Yes.
Yeah.
I think it seems to be sitting well.
Yeah.
So if you're not crossing it easily, don't cross it.
Okay. Now we have crossed.
Go ahead, Shiva. Show us LV before we move on.
15 at 15.
Oh, yes, actually.
Is this the same angio? Can you profile the VSD device properly? Like go a little bit more LAO? Yeah. Little bit more? Okay. There's a lot of contrast on the outer side of the body, I think. Okay. Are we okay? Yeah. Ready to inject? Ready? Yeah. I think the device is okay. However, there probably, since it is a patch-related dehiscence, maybe in some corners, some flows are still there. And also, I would like to wait for some time for, some sort of thrombin, fibrin and all to form over the fabric.
Yeah.
Can you come back to that same LAO?
There could be some amount of foaming also, and maybe some amount of residue.
And Shiva, you're not in a position to check the right heart pressure.
Okay,
no?
now Shiva, we will move over to China. You can take your time doing the LPA. When we come back, you can show us the left pulmonary artery standing. Okay?
Yeah, sure. Here also it looks okay, Bharat. See that? This is just a lot of foam through the device.
Yes, Shiva, we are live.
Yeah, are you able to see me?
Very well.
Very well.
Okay, go to angio.
We can see you well.
Go to
angio.
angio.
With a nice cap you have on.
Yeah, I will get you the same color one. Okay, this was the place where we left you. This was the VSD device.
Please bring one for me.
Yeah, this was the VSD device. Next picture. So then we decided to go for the stenting. Since the hilar left pulmonary artery was 14 millimeter, we decided to mount it on it was a 14. It was a 14 into 4 ZMed 2 balloon with an Andra L stent, which is 26 millimeters long and at 14 millimeter it foreshortens to 22 millimeters. Now after positioning it, next picture.
Okay.
So, so here you can see that we are, just freeze it, yeah, go back. So we are just positioning it in such a way that about one strut is proximal to the LPA narrowing and most of the other parts are distal. Next. And this is our, yeah, this
right.
Freeze it. So this is where we position, go back, yeah.
Yeah.
So then next picture. So then we dilated, we deployed it, go for full inflation, yeah. So this is the final picture. The pressures here were 40 in the distal left pulmonary artery, 45 in the proximal to the stent, and as we entered into the into the MPA, it was between 50 to 55. Next picture. So, yeah, this is the final angiography. Freeze it. Freeze. Yeah, just go back. So, yeah. So this was the LPA stent position and the RPA. Next picture. Then we decided to do the one for the dilated vessel. Freeze it when that MAPCA is seen. Just go back. Go back. Yeah. So this was the place where we had ballooned. And next picture. Next. Okay. It actually it disappeared, but there was not much of staining in that area, and lungs looked fine. One good thing that happened was with the VSD closure, the saturation immediately shot up to 100%, and we were now like, can you show the echo live? Echo live. The saturation immediately shot up the moment the VSD was closed. This is the echocardiographic picture. Next picture. There was still some amount of residual flow. Yeah, some amount of residual flow, but the RV pressure finally has come to close to 50 to 55 when the aorta was about 100. Right now the aortic pressure is about 90 systolic, but at the time it was 100 when the RV was close to 50 to 55. So this was where we completed, and now we have removed.
I think this is excellent.
Yeah, we had removed the sheets. Now Zahid, I want to move on to the other lab, because the other lab has been waiting for long. Can you switch over to the other lab, please?
Sure. Shiva, this is good. I just want to compliment you. This is a very good case that you did. I think I'm very happy.
Thank you very much.
That you did open the left pulmonary artery and didn't listen to some of us here.
Yeah. I mean, I think all of them told left pulmonary artery also has to be dilated, but after the VSD closure.